Bismillahirrahmanirrahim. Assalamu alaikum, dear colleagues. Welcome back. Okay, a 9 years old boy who has recently arrived in the UK referred by GP for the evaluation of a heart murmur. So he has heart murmur, but he is 9 years old. Um, so means since birth he has the murmur, but now he is 9 years old. So maybe has developed some complications of the murmur. He complains short of breath, so he has the short of breath and the blue lips. So now the blue lips came. Since birth it was there, or now they come on moderate exertion. On examination, he plots between second to ninth centile. So also the weight is decreased for the height and weight also decreased. He has no dysmorphic features. So syndromes are ruled out. His heart rate is 110 normal. BP is 115 by 70 mmHg. It's also normal. Oxygen saturation is 90. It is decreased. Oxygen saturation is decreased. He has right ventricular heave. So right ventricular heave is for the right ventricular hypertrophy. Laterally displaced apex. So apex is also displaced because of the cardiomegaly. Loud second heart sound. Second heart sound is loud. Where it is loud? It is at the left upper sternal edge. A 2 by 6 pensystolic murmur. So they given the pensystolic murmur. So now we can limit our DDs here. In the left sternal edge, which is here throughout the chest. So it's hair throughout the chest, but best hair at the left sternal edge. So when they give the history of the blue lips and this cyanotic heart disease, like it has a saturation 90, but this blue lips is the moderate exertion on moderate exertion, and he has a short of breath on the moderate exertion. He has the right ventricular heave. So basically, this patient came with the complication of the congenital heart disease. So pansystolic murmur DDs are the VST, mitral regurgitation, and tricuspid regurgitation. These three are the DDs for the pansystolic murmur. So, here it's fitting with the VST. It's a large size VST. It causes heart to fail, and now the shunt is reversing because he is developing the blue lips on exertion. Means he's developing the Eisenmenger syndrome. Now see what he's asking about questions. Which one best describe the most likely cause of this heart murmur? See the options. Atrial septal defect. Atrial septal defect will cause the ejection systolic murmur, not the pansystolic murmur, and patient do not have these symptoms, the blue lips and the short of breath and loud hard second heart sound. In atrial septal defect, it will be wide and fixed heart sound. So atrial septal defect will be ruled out. Then the tetralogy of Fayette. Tetralogy of Fayette is present early in the life. So with the cyanosis, cyanotic heart disease, spells of TET spells, and the murmur will be ejection systolic murmur due to the pulmonary stenosis, not the pansystolic murmur. Then the large ventricular septal defect. Yes, it is a large ventricular septal defect because it causes the heart to fail, and there is the cardiomegaly, the right ventricular hypertrophy, and there is now developing the Eisenmenger syndrome. PDA has the missionary murmur of continuous murmur at the upper sternal at second intercostal space. So it's not the cause of the PDA. Small ventricular septal defect will be closed by the 9 years. It usually close at that age. If that is the small ventricular septal defect, so it has no second heart sound, will be normal, not loud, and the also not developing the cyanosis. Come to the next question. Considering the second heart sound, which of the following statement is true and the false? Now they are asking about the true and the false in this. Second heart sound. What is second heart sound? It is generated by closing of the atrioventricular valves, means the mitral or tricuspid. No, it is caused by the aortic, generated by the closure of the aortic and the pulmonary walls. It is quieter in children with the pulmonary hypertension. No, it will be harsh It will be more prominent in the pulmonary hypertension, not the quieter. The splitting decrease in children with a ventricular septal defect. It may be increased because, like, see, this is the heart. This is the pulmonary artery. So blood actually is shunting from the this side to this. So it went into the pulmonary artery. So it will increase the, because the pulmonary valve will close later the aortic wall, because the left sided blood is also coming towards the right side in the pulmonary artery. So there's more blood going into the pulmonary artery. So it close after the aorta, more after the aorta. So it will increase, not decrease. So that's why it's option also wrong. The splitting increase in children with the AST. Yes, in AST, it will be increased. Same like the VST. In AST, the blood come from the left side to right side, right atria, then into the right ventricle, then right ventricle to the pulmonary side. So it will be splitting will be increased. It is not associated with the inspiration or expiration or breathing pattern. It will increase and it will be wide and fixed. It will be wide and fixed. Wide and fixed. So it's the correct answer. Now see the last option. The splitting is decreased by inspiration. No, splitting is increased by the inspiration. What happened in into the inspiration? In inspiration, the intrathoracic pressure decreased, and the diaphragm going downward. So it make pressure on the viscerals. The venous drainage to the cardiac is increased into the right atrium, from the right atrium to the right ventricle, then the pulmonary artery. So the right side is closed, right sided wall is closed a bit later than the left sided wall. So that's why the during inspiration, the splitting will be increased, not decreased. So it is also wrong. So answer is the D, splitting increase in with the AST. The next question is also true and false, but for the ECG. They are now asking about the ECG. See the options. The electrical impulse start in the SA node in the wall of the left atrium. SA node is not in the wall of the left atrium, it is in the right atrium, not left. Second is the PR interval is the time between the onset of the atrial repolarization and the onset of the ventricular depolarization. So I have to make a ECG. So in ECG, I will show what is PR interval. Actually, it is the correct answer, but I will show how the repolarization and depolarization occurs on ECG. So it is a ECG here. Let me change the color so that it will be visible, easily visible. So what is the PR interval? PR interval, say this is a P wave, arterial depolarization. It is the Q above R, below S, then the T wave. So simply these are the present in the ECG. P for the atrial depolarization, QR is comprised only shows the ventricular depolarization, then the T wave is repolarization of the ventricles. Now, what is PR interval? PR interval is basically nothing but the start of the P wave to the starting point of the QRS complex here. So it is the blue line is the blue gap is the PR interval. Okay. Now what is QT interval? Starting, let me change the color. Starting from the Q wave onset of the QRS complex to the end of where the T wave is end at the baseline, it is known as a QT. So this green is QT. Okay. This blue is the PR interval. Okay. These are the few things about the ECG. Now again come to our topics. So the C point is the T wave represent the period between the end of the ventricular repolarization and the beginning of the arterial repolarization. No, T wave as I shown in the ECG, it is the ventricular repolarization. It's not the end or the beginning of the arterial repolarization. It is the ventricular repolarization. So it's a wrong answer. Now D option, ventricular repolarization is presented by the QRS complex. No, ventricular depolarization is represented by the QRS complex. Ventricular repolarization is represented by the T wave and not the QRS complex. Ventricular depolarization produce T wave. No, ventricular repolarization produce the Q wave. So last 2 points are opposite to each other. If you see here, so you know the basic ECG has been studied here in these options. So now come to the fourth. Which one of the following statement is most likely to be corrected regarding the ECG finding in this patient? So in our patient, there was the right ventricular heave, the apex was shifting laterally. So there is a chance of right ventricular hypertrophy. So let's see what are the options here. A dominant R wave in lead V1 is it an indication of the right ventricular hypertrophy? Yes, it's an indication of the right ventricular hypertrophy. But in our patient, it is a finding in normally the right ventricular hypertrophy, a dominant R wave in the lead V1. So it might be correct. Let's see other options. A mean frontal QRX is more than 90, indicator of the left axis deviation. No. For the left axis deviation beyond the -30 to -300 degree, it is the left axis deviation on the 30 degree left axis deviation. Okay, more than the 30 degree. Okay, what is normal axis? It is between the -30 to 90 degree, positive 90 plus 90. Normal is from -30 to plus 90. Beyond the 90 is right degree, right axis deviation. Beyond the -30 is the left axis deviation. Between -30 to plus 90 is normal. Okay, guys. So they are saying the ECG will be normal. No, if there is a right ventricular hypertrophy, so there will be changes in the ECG. Q wave will be present in anterior chest leads. It will be normally present, but in our cases, it is not the case here. Q wave. The P wave will be shortened and narrow. No, P wave has no effect. P wave is related to the atria mainly. It is atrial depolarization. If it is peak, then there is a right atrial hypertrophy. If it is widened or prolonged, so then the left ventricle. We will study below. So the first option is purely correct here. So there is no computation with other options here. So this was a case about the VST. Now presenting with the Eisenmenger syndrome with the complications. So the first was a large ventricular septal defect. Our answer was correct. So see that all the options are false. Only D is true. What was a D here? D was a splitting increase in children with the AST. Now the other option 3, second is true and other are false. So what was that? The second was, there you can see this, the PR interval, that the time between the onset of atrial repolarization and the onset of the ventricular depolarization. As I shown the ECG. Our dominant R wave in the V1 shows the right ventricular hypertrophy. The murmurs. Here they told about the murmurs. So I will make a diagram and make you clear. So this is the S1. S1. This is the S2. This is again the S1. So it is the cardiac cycle. Cardiac cycle has the 3 phases. One is the ventricular contraction, which occur between the S1 and into S2, and the ventricular relaxation and the filling, which occurs between the S2 and S1, which is a diastolic phase. So ventricular contraction is the systolic phase, which is between the S1 and the S2. This is the systolic. Clear. This red line is the systolic, while this black line is the diastolic. D4 diastole, S4 systole. Now the murmurs. What are the murmurs of the systole and the diastole? So basically, in the systolic has two murmurs and diastolic has also two murmurs. Systolic has two murmur. One is the ejection systolic murmur. Means when the blood, when the ventricle is contracting, initially eject means the blood is going into the aorta or the pulmonary side. So if there is a problem in the pulmonary wall or the aortic wall, it produces the sound, abnormal sound. It is known as the murmur. So ejection systolic murmur is like this. It is start from the S1. I'm marking this line to mention the, see, initially it starts, but it is not wall in the between the S1 and S2, not during wall the systole. It's only in the early phase of the systole. So it is known as the ejection systolic murmur. So what are the differential of ejection systolic murmur? Remember the names only. Pulmonary stenosis, either single or either associated with the tetralogy of Fallot, and the aortic stenosis, and the last one is the atrial septal defect. These three are the differential for the ejection systolic murmur. Ejection, EJ means ejection, systolic murmur. I made the EJSM. Then the pansystolic murmur. Pansystolic murmur means it starts from the S1 throughout the systole. It is sound is producing, murmur is producing. So whole systole has the murmur. This is known as the pansystole. Pan P systolic murmur. PSM, pansystolic murmur. So what are the differential of this? So pansystolic murmur is either due to the mitral regurgitation, or tricuspid regurgitation, or the ventricular septal defect. These three are the DDs of the pansystolic murmur. Now come to the diastolic murmurs. What are the diastolic murmur? Diastolic murmur are two types. One is the early diastolic murmur, other is the mid diastolic murmur. Early diastolic is like the ejection systolic murmur. It appears start in the starting, but initial phase of the diastole. It disappeared in the late phase of the diastole. So initially it starts, then it ends. So what are the differential? Differentials are pulmonary regurgitation and aortic regurgitation. It causes the early diastolic murmur. Now come to the mid diastolic murmur. Mid diastolic means it starts in the middle of diastole and it ends in the middle of the diastole, like this. So this is the S2, this is the S1 here. So it is between, it is in the center of the diastole. So differentials are mitral stenosis and the tricuspid stenosis. Just remembering and ratify these. So last one is remaining here. So I try to picture here. Last one is the it is the S1. Okay, this is the S2 here. This is the S3 here. This last murmur is start here to the here. Means it's continuing during systole, during diastole. Uh, it's not limited to systole or diastole. It is continuing. It is continuous murmur. It is murmur of the PDA. PDA murmur is the continuous murmur. Okay, I think the murmurs are clear. So that's it for the today. So if any questions, you can ask me directly with any WhatsApp or any message or voice message. You can ask anything about this. I hope this video will be beneficial for you all guys. Thank you. Allah Hafiz.